Hi, my name is Margaret Sherritt, and I'm happy to be presenting today on exploring the impact of COVID-19 on infant feeding within our hospitals and our community. And then together, we're going to put our heads together and talk about some regrowth opportunities. So I want to acknowledge that the land on which I reside and work is located on the Haldeman Tract, land that was granted to the Haudenosaunee of the Six Nations of the Grand River, and is within the territory of the neutral Anishinaabe and Haudenosaunee people. We acknowledge the enduring presence of the Indigenous people with whom we share this land today, their achievements and their contributions to our community. The goals of today's presentation, we're going to look at some of the present day reality and the aftermath of COVID-19 on infant feeding BFI practices. We're going to have a little quick look at some of the data. We're going to look at some of our reality that we've been left with within our organizations. And we're going to do some brainstorming. When I started preparing the presentation, beginning of November, we're rolling into Remembrance Day, the day that we're honoring all the Canadians that went to fight for our freedom. And the numbers actually, when I critically looked at the numbers, they were actually quite striking the parallel, because COVID, has been referred to as the war on COVID. And that's where, let's really look at the numbers and how striking they are. So World War I, 56,638 Canadians lost their lives in the fight for freedom. And that was over a 4-year period. World War II, 42,042 Canadians lost their lives over about a 4.5-year period. And as we roll into COVID, the latest statistics that government has been gathering as of November 21st, they're reporting 55,000 deaths related to a COVID diagnosis for Canadians. And that's basically over a 3.5-year period. So when they say, that war is this, or COVID is this generation's war, I tend to agree. And so when we look at the distribution, so of course, we know that the elderly have been impacted most with fatalities. But then when we look at the age and gender distribution of the disease, is actually the highest incidence is in the populations that we work with. So the 20 to 29-year-olds are the number one population, and the 30 to 39-year-olds are the number two population. So when you kind of look at the numbers, mat child nursing, that's what areas most of us work in, they're the two highest incidence populations. So the Canadian Institute for Health Information, so much of the press focus has been what we've had to do in hospitals to help assure we have bed capacity. But the Canadian Institute for Health Information has actually come back and said in 2021-22, this is an infographic that they've just put out, the top 5 reasons for hospital stays in Canada, and number 1 is actually giving birth. So 200,000 babies approximately arrive in Canada each year. Number 2 is COVID. Number 3 and 4 is heart. And no surprise that substance use disorders are rearing their heads with all the stress with COVID. And their data actually spoke to some surgeries too. So the most common inpatient surgery in Canada in those target years was actually cesarean sections. And they state, the average length of stay is 2.7 days. And I think some of that data is probably impacted by, of course, there was times when the ORs were closed. And the total C-section rate in a short amount of period has actually bumped up. So 2017, 2008, roughly 29% if you round it up a bit. And then 2021 to 2022, they're basically saying it's 31.7. We can round it up to 32%. So any of us working with breastfeeding families certainly know that C-sections can cause moms to have a little bit slower start with infant feeding. So important numbers to remember. And also the population, the numbers that are going through the hospital are real. So we have our foundation, the underlying base of support. Public Health Ontario 2023 briefing statement states poor nutrition, especially in early childhood, is the leading risk factor in the development of non-communicable diseases, such as cardiovascular disease, cancer, stroke, and diabetes. In 2016, research identified 12% of all deaths in Canada could actually be traced back to poor nutrition. Breastfeeding in the first 6 months of life provides short and long-term outcomes. So we need to build that foundation of our health with good nutrition right from day one. But I think today I'm actually singing to the choir with that. And we cannot build the house before we build the foundation. So if we kind of circle back, if we're talking about the impact of COVID, we can't forget the reality of the workforce. And I'm going to speak from my lived experience in the early part of COVID. So throughout the pandemic, there's been key moments etched. Initially, my quiet drive to work with hardly anyone on the road. The silence, because I turn off the radio to deafen that COVID noise. The envy of those professions the envy I felt of those professions that were able to stay home. The relief that my adult children were among them. The relief being able to talk with my peers at work. The fear was strong with the initial shortages of PPE, leaving my mask in a paper bag for reprocessing. The thought was terrifying. The unknowing, the changing regulations and rules, the fear of transmission and taking it home. The hard conversations. Well, my first conversation is, well, I'll sleep in another room. But then I resorted to bargaining. I'll strip in the garage. I'll shower really quick, and then I'll rinse the shower back down with Javex. And wait, you know what? You can't go out and do groceries. Let's admit it. I'm already the moving target. I'm doing the grocery shopping. Thoughts of those red cape wearing and banging on pots and pans. It didn't do much. It was maybe a nice thought, but only made the reality of what we were facing actually a little bit tougher. And Shaw, the research is coming out now about the impacts, as we continue to live with COVID and the impact on healthcare providers. The constantly changing guidelines and rapidly changing conditions caused higher anxiety and depression. I think we can safely say this is across every population. But remembering too, the healthcare provider as they're at work kind of dealing with the constant changes, they're also dealing with those constant changes in other parts of their lives. So no childcare, homeschooling, worrying about elderly parents that you were essentially barred from seeing. The shortages, the prices, the reality continued for them. The foundation was starting to crumble. So in the early months, clinicians were told that if you provided direct patient care, there was a threefold higher threshold risk of acquiring COVID than the general public. And nurses were told to consider the effort of dressing in and out of applying PPE gowns and equipment because they were in short supply. So basically the message was get in, get out of the room, and don't be going back in and out if you don't need to be. So how did this circle down into the reality of providing feeding support? And Hoying, in her 2022 study, she actually polled nurses. And basically 56% of those nurses reported the recommendations to minimize time spent in the room hindered their ability to help women breastfeed. And remember that 15-minute rule. So basically, if you were if an exposure point was considered if you had been with somebody for more than 15 minutes and then they actually tested positive for COVID, then you were an exposure point. So I think all of us working with breastfeeding families know that 15-minute rule is ludicrous, because if you're interacting with a family, it's often an hour later. So it was always back to that kind of a little bit of a moving target. The masks definitely became an icon for COVID. And I can almost chuckle when we say, like, wearing the mask. Yes, of course, it makes it difficult to speak at long lengths. And of course, when we're helping facilitate supporting infant feeding, we're doing a whole lot of talking, and it's often for extended amounts of time. So as we, move into that N95 stage, when we had that option and they were available, they actually made you quite short of breath. And then I almost smile at kind of the picture that was happening for many healthcare providers, because now you've got the mask on, you've got your glasses, and then you're going to stick a set of goggles over top of that, and how they all fogged up and stuff. So, I think we can smile now, but oh, it wasn't fun. And then also kind of the communication point. So yes, we have our face, right? Our face, our words say one thing, but our face actually helps support that communication. And my husband reminds me of that all the time when I talk. So then when I put that mask on, my communication is impaired. And then when the person you're working with has a mask on, sometimes the communication, actually, your words may be saying one thing and it's not heard as well because of the face part, the facial gestures and stuff just are impaired because of the mask. So then when we kind of circle through to the sorry, we're closed, how can we forget this was the reality for new families, and new families for quite a period of time? So remember the first lockdown, when even the private IBCLCs were shut down. There was no peer support. Prenatal and postnatal visits were being done by the phone, and referrals only, visits only if essential. And even for that essential visit, it was the waiting in the parking lot to be called into the office. Thankful for pivots, we were able to pivot to virtual medicine. The OTN network was a great kind of bridge support to that time. And also remember the reduced lengths of stays and the decreased follow-up supports actually left us with little options. I actually experienced fear sometimes, fear of discharging a breastfeeding family that wasn't doing well. And at points, actually, it was anxiety provoking, because you just knew the web of support was not there. Were these memories or nightmares? Well, I'm not quite sure which is right for that period of time. So we have, our public health nurses that are leaders, okay? Leaders in protecting and promoting and preserving our health. And they had to do the quickest pivot, probably the quickest pivot in history. And they had to kind of step up and accept a lot of roles and responsibilities. Roles and responsibilities that they undertook were extensive: outbreak management, contract tracing, case management, organizing and leading mass immunization clinics, COVID swabbing, infection prevention and control. Probably the most difficult was communication. They, part of their programming is, of course, communicating credible and evidence-based advice to the public. And we certainly, if you look back on the black and whites that were happening and all the opposition, oh, not an easy time. So HBHC, we know that with the pivot of the programs, a lot of programming that they invested years and years of developing and growing their own education and capacity in, those programs had to be downgraded or stopped because those human resources needed to be put towards the COVID effort. So there was a briefing just recently about HBHC, and there was actually some important lessons that they said that as they had to then start to revamp the program, that they actually had to critically think about. And I think it's actually almost some of this parallels for us right now. They had to consider, as they revamp their program, look at client complexity, the structures and operation changes in agencies. And don't we know that there's been so many changes, and the need to reinvest and build that partnerships again. And also to remember the manpower, because we all know there's a shortage of healthcare workers. So when I kind of now circle back to the shortage of healthcare workers that we need to consider, maybe one of the collateral damages of the COVID was the crumbling workforce. And it's no surprise that Stats Canada last month actually came out with a report about job vacancies. And they took 6 of the professions with the top job vacancies in Canada. And I don't think it's any surprise to anyone that healthcare workers were in the top 3. But what is a surprise, despite all the efforts to try and backfill the positions and kind of revamp the system, that according to their report from 2022 to 2023, the actually vacancy rates, the jobs that are left unfilled, have increased by about 24%. So that's a scary statistic, despite all the efforts. And the Canadian Federation of Nurses Union, they did a poll of the 4,467 practicing nurses in Canada. And the results are actually scary. 59% of early career nurses, so that's the 0 to 2 nurses that are working from 0 to 2 years in their career. 56% of mid-career nurses, those are nurses that are working from 2 to 20 years, and 20% of late career nurses state that they're considering leaving their job within the next year. But I think that we need to preface that too. Some of the early career nurses, the advantage of your early career is you tend to want to find your spot, your clinical love in nursing. So you tend to move around a little bit till you find that spot where you want to be. So some of that may be weaved into that number. But if we kind of look at the 19% down below, we can't ignore that. 19% of nurses, they say, are considering leaving the profession altogether. So the backbone of, building capacity in the system. So 1 in 5 is saying, I'm going to leave. We can't ignore that number. And, kind of that reminder that many of the newer staff, that early career nurses, they had their clinical experiences were almost non-existent through COVID. So yes, they had their clinical learning, but they didn't have the advantage of a lot of those clinical placements. So the mentors, the older nurses, were often mid to late career, and they were left to try and bridge some of those learning needs for the younger staff, the newer staff. So, and we all know that enabling and supporting infant feeding is a key element in providing safe care, and education was difficult through this time period. And to say now we're actually watching as we're re-emerging, how some of the virtual platforms are actually filling the bridge quite nicely for education. So that we know that pregnancy and birth is primarily a social experience in which care services support not only the medical health and well-being of patients, but also the development and growth from an individual to a parent. Key, we're helping to grow a parent, probably the biggest job you've ever been given in life, right? With the least preparation. So the whole tenets of maternal child nursing, the partnership of hospital, public health, community partners, and peer support. Well, that's actually step 10 of the baby-friendly framework. The reality that care could not be delivered in the way it could and should be for almost 3.5 years as we're, wiggling our way back out of it. It's a long time period for things to be paused. And, this picture, how can we forget those early months of isolation? And this was reality for many families where basically their net of support was gone. So as, I assume it's a grandmother in the picture is standing on the other side of the glass. And this was for months and months until immunization started to build, increase. And then there was other options. So basically this statement from a study done in Nova Scotia about breastfeeding experiences sums it up beautifully for that time period. It's basically illegal to have the village to help raise the child. So as they've started to unpack some of the research now, Lube has kind of looked at some of the problem areas in the early part of the pandemic and some of the messaging that caused some issues. And let's acknowledge we didn't know what we were dealing with. And so many facilities made rapid decisions based on, because we didn't have the research yet. And so there was a tendency, if there was any COVID, if mom was COVID positive, that there was mom and baby separation. And it was separation for extended days at points. Skin to skin was discouraged in some centers because they just didn't know. And inpatient support could have been decreased, and it was part of the staffing. As staff were succumbing to COVID too, that you didn't have full staffing complements. So sometimes the support you could was very, very stretched. And we certainly know the outpatient support, at points in time was almost non-existent. And when I mentioned fear, and this is once I circle back to my lived experience of fear, there was almost at points in time where the parents were fearful of the healthcare provider. And of course, providing one-on-one breastfeeding support, you are in each other's space. So there was many, many instances of the body language of fear when you arrived, where almost like their body kind of closed in, the shoulders, it's like, oh no. And how often sometimes breastfeeding support, when you've seen that kind of body language, and it was not uncommon that often they relaxed when you kind of moved and found your spot to sit in the room, not as quite as close. So, how we almost had to revamp some of what we were doing with breastfeeding support in order to make it work. And, positives, of course, from anything negative, positives arrive. And some of the positives that emerged was increased partner involvement. And I think we can all smile working with families about the no visitors, because we've seen we've seen in SARS how actually in SARS, a comment because we actually tracked it, where we didn't have one big weight loss more than 10% in that period in SARS, because people were concentrated on their time with their babies. So once again, we've seen this again through COVID, where when parents had no visitors, that they were able to concentrate on their needs and their baby's needs without trying to balance the needs of visiting. And so we had better rested parents that were more receptive to teaching. But also we had babies that were more feeding cues and things like that, cueing more. They didn't do that baby possum stuff that they tend to do when they're handled from one to the next visitor. So, definitely an observation. Increased use of virtual support. And there is, mixed reviews about the pros and cons of that. So food insecurity, and once again, Stats Can. So in 2022, 18% of Canadian families have reported food insecurity. And I would almost challenge, I wonder if 2023, we're actually going to see that number be higher, because, inflation continues and mortgage rates are increasing and stuff like that. So whether that number is going to be actually higher on the next round. But basically, 1 in 5 families that we work with are experiencing food insecurity. And formula insecurity is real in Canada. Formula for Canadian babies is actually not made in Canada. So we've had lots of supply chain issues and shortages, especially as a result of a major manufacturer in the States, supplier, that has had to close down for how many incidences? I think it's been 2 or 3. And initially, we've seen the initial hoarding, we've seen the shortages, the price climb, and now they say it's actually climbed beyond the level of inflation. And next time you go to the grocery store, I actually really challenge you to walk down the baby aisle. I challenge you to kind of look about, because this picture is from a local grocery store where I live, and you can see the formula is behind a locked cupboard. Another local grocery store where I live, if you look up, you see the camera recording your every movement and telling you about it. And that's just a statement of what a theft item that is. And it's actually it's really a sad state when you think how you feed your baby is actually under lock and key and a camera recording your movements. recently working with a family. I call them, the COVID babies, because she's on to her second COVID baby. She was very intent on making breastfeeding work, like very, very intent. So I asked her the question, what made the difference from your second baby to your first baby that you had bottle fed? And she says she can't let history repeat itself for her for that first year, where she had to actually switch around to all different formula brands because it was like whatever she could basically get is what her baby got. And she said she spent a year worrying about each time she went to the store whether she was going to be able to get what her baby needed. And it's actually a tragic state of affairs. So when we kind of look at Ontario data, and this is on the right-hand side of the screen is the Ontario Baby Friendly Initiative report. This is just a print screen from their report using the Born data. Born data is the database that they collect birth statistics on every baby born in Ontario. And part of that is the Baby Friendly Initiative breastfeeding data that they collect too. So you can see through the years of with the initiative that strategy that breastfeeding rates gradually climbed, and that there was a nudge in the exclusivity of breastfeeding and a nudge in the adjusted breastfeeding rate. And then kind of if you wiggle over onto the left side of the screen, the data through COVID, 2018-19 before, and then through the last 3 years. So you almost see the same climb. So you can see that the initiation rate, and this is province-wide, of course, there's areas that are higher than this, but this is the average in Ontario was 84%. But by 2022, that the numbers were nudged to about 88%. So I think that's, that you could do a whole study on those numbers, but I'm sure it's related to the costing, the supply of formula, but also to the messaging with public health about the importance of how antibodies are protecting babies against COVID. So lots of facts, I think, in there. And then, the number that we're gauging ourselves on, this magic 75%, so breast plus medical sup, you can see actually it was pretty consistent throughout the last 5 years. So that's actually, in some ways, it's reassuring. It's certainly not as high as we'd like, but the fact that it stayed consistent is reassuring in the fact that, well, there was messaging, there was tenets of support that continued because our numbers basically maintained, even if, on the next breath, we want to see them higher. And then, exclusivity, the gold standard of what we're aiming for, nudged down through COVID. This is the Breastfeeding 2022 report from Public Health Agency of Canada, and it reminds us that 1 in 3 infants actually meet the goal of at least 6 months of exclusive breastfeeding in Canada, and that the target for the international target that WHO and UNICEF is aiming for is a 70% exclusivity rate at 6 months by 2030. So you can see that got some work to do if we're going to meet that international target. So what about BFI designated facilities? Well, government policy actually helps, remember, to build the foundation, and evidence of investment in 2011, when the Ontario government weaved baby friendly into public health accountability agreements. Health units worked really hard. And by 2017, 31 community health centers, the majority of them being public health units, and 8 Ontario hospitals had joined the 20,000 that were globally designated. The BFI strategy worked to build capacity in hospitals. Mother Risk and Best Start also supported building capacity. But those 3 programs were eliminated, and not like the accountability agreement, the strategy that worked with hospitals, and Mother Risk. So they're just not in the picture anymore. and Best Start took a directional change. And interesting in, the work that I do with BCC, many provinces still look out for the Best Start resources as they were recognized as being top notch. So to say it's disheartening to watch the Kenyans providing a foundation for health crumble to 4 hospitals and 6 community health centers in 2023. It is disheartening. It's disheartening. We know the tenets for this framework are actually about building safe care delivery. So just a reminder that I love this quote from the Lancet breastfeeding series: the success or failure of breastfeeding should not be seen as solely the responsibility of a woman. Her ability to breastfeed is much shaped by the support and the environment in which she lives. There's a broader responsibility of governments and society to support women through policies and programs in the community. So remember the crumbly foundation that I started with earlier in the presentation? Well, when I look at this foundation, I actually see the braces. And when I look at the braces, I actually see each of you that are attending today. Each of you attending have been working as a brace to actually help hold this foundation together. It is through the community of collaboration that we'll be able to step forward, because don't we know together is always better. So I'm back. This is an enlarged picture of that crumbling foundation, actually from the beginning. And this is actually somebody I know. This is actually their foundation. So this foundation, the homeowner actually had some really tough decisions to make to keep their home safe. They decided to rebuild their foundation instead of knocking the home down. I firmly believe that each of us here can be a change agent to help rebuild our foundation and practices to safe care. Baby Friendly gives us a framework and embraces and uses quality improvement principles to shape change and give us principles to deliver safe care practices for each baby, whether you decide to breast or formula feed. It supports principles of attachment and once again, safe care delivery. I'm really thankful for my time as a Breastfeeding Committee of Canada Coach Mentor Quality Improvement Program. In the last 2 years, I've actually seen the winds of change have blown strong in several provinces and territories when the government recognized we need to invest today for tomorrow. I've witnessed the momentum change grow when teams come together to support and challenge each other with their mutual goals. Baby Friendly is about providing safe care across all healthcare sectors, upstream thinking that builds a strong foundation. Yeah, it's going to take some time. And yes, it's probably going to take funding. Let's stop the crumbling foundation and start to imagine really what Ontario, the most populous province, can do as we start to rebuild, as we are now learning to live with COVID reality. Promote, protect, and support. Those action verbs that are important as we embrace the work, as we imagine a path forward. Some things that I want to encourage you to do is pop onto the Breastfeeding Committee of Canada website and listen to Dr. Sandra Hoy's presentation about cost savings. So she has become the voice of the study that she's done, and it's going to be released soon. Actually, it's a peer-reviewed international breastfeeding journal. And in her study, she looked at the Ontario and looked at 5 different illnesses in children, and then 2 in moms. And they say a potential savings of 17 million in healthcare dollars. So if you think healthcare dollars, these are actually your dollars as a taxpayer in the province. So I'm going to move on, and Louise is going to help unpack some of the other things that we can actually help to start to do to advocate. Are you there, Louise?
There I am. Sorry, I was muted. Thank you, Margaret. So I just want to, before we get into talking to all of you, I just want to share a couple of things that has been going on with the BCC that can help to move us forward as well. You may have seen, or actually at our last meeting, Marg had talked about the code and some of the work that BCC had been doing. And so just a little bit more of an update on that. So talking about the International Code of Marketing of Breast Milk Substitutes, there is a unique opportunity to advocate for the adherence of the code within Canada's regulatory framework and to address the shortages of infant formula and food for a special dietary purpose. Health Canada plans to modernize a couple of the areas of the food and drug regulations. Health Canada intends to launch a public consultation this fall to seek input into this. And Mark had mentioned this, as I said, at a previous meeting. And so what the BCC has done is they created a new code working group within BCC to help them prepare for Health Canada's public consultation. And so they've created a few resources to help support this cause and to gather information. They've created a briefing note called Adhering to the WHO Code in Canada. They've also developed a survey about the code, including an option to send an individual letter to your member of parliament, or an option of BCC to be sending a letter on your behalf. And they've also developed a Facebook page called Keen on the Code. And so at the top of the screen here, you can see a little snapshot from that Facebook group. And we encourage you to visit and to follow their Facebook page. And from here, you can keep up to date with the opening of the Food and Drug Act and the opportunities to change the wording of that act to better include the WHO Code and subsequent resolutions, WHA resolutions. We will be sharing this Facebook page next week on our social media sites, and we'll also include information on our website and sending out an email to all members for a call to action and how you can help in this regard. The more who complete this survey and take part in the letter writing, the better. This is how we can advocate for implementation, monitoring, and enforcements of the tenets of the code in Canada. And our country is far behind other countries in this regard. A couple of other briefing notes to help you move forward within organizations and to gain support for breastfeeding and BFI best practices is that they've created a couple of other briefing notes as well. One called Scaling Up BFI in Canada, Improving Canadian Breastfeeding Rates and Maternal Child Outcomes. And the purpose of this is the scaling up of BFI implementation in Canadian hospitals and community health services, primarily public health, to improve breastfeeding rates and maternal child outcomes. And we encourage you, we're going to be sharing these, and so we will be encouraging you to share these with your leadership team. And also the third briefing note that they've come out with just this past week is Public Health Surveillance and Core Competencies, a briefing note titled Modernization of Canadian Public Health Surveillance and Core Competencies to Improve Breastfeeding Rates and Maternal Child Outcomes. And this note will speak to working in public health. And again, we encourage you to share that with your MOHs or other management. These briefing notes are being translated into French, and so they will be available. So we will be sending, stay tuned to us to be sending these out to you in some emails within the next week or so. So that's sort of the end of the presentation, but we want to move on to reigniting and opening up discussion for you to share what you have been doing. So I'm just going to stop recording here.